Sherry talked about everything above the tentorium in the brain, and we're going to talk about everything kind of below and in the face. So there's some slides. First of all, before we start, does anybody remember this year? Remember the story? All right. Leslie Smith, UFC 180, and she apparently walked in with a cauliflower ear. So in the middle or towards the end of the fight, she completely opened up this cauliflower ear, and it was basically dangling down. And Howard Dean, great ref, I think was a little perplexed as to what to do, because this obviously isn't life-threatening. I mean, it's cosmetic to a point. The doc looked at it once, and it was kind of still together. I think they let the fight go on for another 30 or 45 seconds. And then it just became obvious that this ear was about to fall off. So I think somebody probably made the right call, to kind of, step in and call the fight. And this fighter, Leslie Smith, protested loudly. I mean, she couldn't see her own ear, I think, as part of the problem is. But she really, really, kind of protested until after the fight, and she got to look at what her ear looked like. And I think at that point she said, okay, maybe, I'll accept that was a good stoppage. But it's along the same lines of these guys want to compete. I mean, they really want to compete. And sometimes to their detriment, especially on something like this that's not necessarily obvious to them. Believe it or not, on some of the MMA websites or whatever, they still had discussions about whether this was a good stoppage or not. But I think the consensus on the medical end was, even though it is cosmetic, I mean, this fighter, male or female, is going to have a life afterward, and it'd be nice if that included 2 ears, which, she might not have. So, I mean, talking about, head neck injuries or facial injuries, I would change that most into probably all combative sports. Participants are going to sustain injuries to the face, head, neck, and ear. I mean, it's pretty obvious, who's been doing this and who hasn't. And we'll talk about, identifying risk pre-fight. We'll talk about, ringside diagnosis, stoppage. Obviously, we had a little discussion about that, and some guidance for the post-fight and things like that. Again, probably a little less serious until you get into CSF leaks or things like that than what we already talked about. But still, obviously very important to the fighter, very important for sensory function down the road. When we're talking about ears, nose, we're talking about major organs, include balance, those sorts of things. So we'll talk about the kind of the different categories, starting with ears. External, obviously, we see that. We see it all the time. Lacerations, hematomas, to basically what you see on the outside. Middle ears, eardrum, and those kind of functions includes the small bones of hearing. And then the inner ear, we're talking about mostly balance, labyrinthine function, things like that. Everybody remember this fight? 97? This was Holyfield Tyson 2, I think. MGM Grand, and there's a nice little shot of poor Holyfield after I think that was the second bite, because it took 2. Auricular Hematoma is the classic cauliflower ear. Accumulation of blood right underneath the cartilage, pericardium. Everybody know the big risks here and the sequela of that, the cauliflower ears, the destruction of cartilage. That kind of goes on in the setting. So very common injury, more so in MMA than boxing, but certainly, the boxers experience it as well. Tympanic membranes, you're not going to see this without an otoscope or some sort of speculum to get further in here. But normally this is nice and shiny and pearly, and it doesn't have a big hole in it. So the majority of perforations are here towards the back. The posterior seems to be the weakest. And there's the opening of the ear, there's the canal, where everybody gets the wax, and here's the membrane itself with a nice little hole on it. It can scar up later on, sometimes when you're doing the exams, and you'll see, these little whitish areas on the eardrum. That's either a previous perforation, or perhaps as kids they had tubes or something else that was sort of abnormal. It's very rare to see a perfect eardrum, especially in combative sports. Round window is this small little area, actually. Here's the eardrum we just saw. It is the next kind of enclosure, and it is right next to all the organs of balance. So looking at my little hand here, eardrum goes here, through these three bones communicates hearing into the organs of both hearing and balance. The canals of balance are up here, very delicate structures, include flowing fluid, very similar to spinal fluid. And then the cochlea, like a shell, is the organ of hearing. So very important structures that are kind of just within reach of a boxing glove via the external forces that you can put on an ear during a hit. Pre-fight, talking about facial lacerations and kind of what to look for pre-fight. Everybody has seen these kind of European fighters that come in with very sharp, orbital rims and very prominent eyes. You'll also know them because they've, their eyebrows are interrupted from prior cuts and everything else like that. Shallow rims with the bug eyes, also more prone to it. Look at your cheekbones. Those are going to be exposed later on. The jaw, the fellows that are breathing through the mouth and having trouble keeping a mouthpiece in. And of course, prior lacerations are your best guide to what to experience on them. I think everybody who did a Gotti fight probably expected him to open up, at some point, and he was usually doing that. From our role as guidance in these things, it always becomes the issue of stoppage and kind of what to do. And these are fairly common. I know the refs have very experienced in it as well. We had one in last night's fight that was close in this region, but certainly visual problems, asking the fighter about vision, quick hand counts or other things, covering up one eye at a time will give you a hint as to whether there is. Ask them about double vision, and we'll talk about that later, related to orbital fractures and disruptions in the eye socket anatomy. Respiratory problems, checking for breathing, although most guys will get stopped up at some point. And then obviously, as we saw in the first picture with the ears, severely macerated tissues from a cosmetic point and also from a functional point later on. The big thing in brows is if you're, or eye cuts, if you're seeing anything around the lid or anything around the tear ducts centrally or around the artery up here, those are fights that have to be stopped, even if the cut itself isn't impressive or the bleeding is impressive, just from the structures underneath. From our standpoint as kind of first aid, at the ring, just basically pressure, and then refer onward or have them kind of evaluate it later on. I can't remember this fight, but this came in on a quick headbutt, and it grew in a matter of seconds. So this fellow went from a normal appearance to this huge tomato, which potentially could have interfered vision. But I think as long as vision's okay, I don't know. We can take a survey. Would y'all let the fight go on? I mean, if he could see okay or anything, no. Okay. He'd probably complain about it, though, right? I mean, if he could see and defend himself, who would let the fight go? I'm just curious. Yeah, I think I would too. Yeah, Sherry, yeah, I think so too. I mean, certainly, the corner can kind of work on this a little bit in between, but if his vision's not interrupted, if he's got binocular vision, if the eye structures are maintained, I don't see a huge reason here. You'd obviously have to keep a close eye on it.
What's the worst that can happen from that?
Yeah, he's going to look terrible for a couple of weeks. It's a judgment call. I mean, there's no right or wrong. I think this fight did continue, though. I don't think there was a stoppage. And, I mean, it looks horrible. And we talked about cosmetics on the ear with the MMA fighter. But I think the cosmetic implications, are probably scarier than the functional, But yeah, that thing's going to be huge, and it's going to take.
I remember a fight with two of them.
Double. The guy looked like he had horns on him. Huh? Yeah. Did they went on, right? Okay. Yeah. And I think amateur versus professional. I mean, are these guys starting up? Are they at a level where they're willing to put it on the line, and versus somebody who's just starting out and maybe can come back and do something else. They're all judgment calls. I mean, that's kind of what we live for, and that's where experience. This doesn't take an MRI, does it? Yeah, pretty obviously. So yeah, nasal fracture. This poor fella. This is a little bit about anatomy, probably more than most non-physicians need, but just to understand the complexity of what we're talking about. I mean, this is multiple bones. This isn't just one. So I mean, starting with the skull, the obvious forehead, which comprises the upper portions of the orbit. The smaller nasal bones, everybody's seen these things break. And then you get into the zygomatic, which is cheek and above, which also forms the floor of this, of both orbits. And then internally, you'll see this sphenoid bone, which forms the inner wall of the orbits. Extremely delicate structures. You're talking about, millimeters, and it's just amazing we don't see more of these injuries. When you look at the size of this, the thinness of this and the delicacy of this. So, extremely important for this. We'll talk about nasal trauma here in a little bit. So, apart from fractures, and the obvious stuff, there's a host of other injuries that to be on the lookout for, including all the soft tissues that we've talked about. The septal cartilage hiding in that midline of the nose, and you got to lean back a fighter, and you've got to it'd be nice to have a light or some speculum to kind of see what's going on there. Both dislocations and fractures are possible in this region, as well as a septal hematoma. And the clue to that is going to be leaning a fighter back and looking for one or both parts of the septum extending outward, checking for patency of the nostrils, that sort of thing. We talked a little bit about cerebral spinal fluid and leaks on the brain portions, and because of the thin bones towards the base of the skull or the skull base, there certainly exists the possibility that if you're seeing clear stuff running out the nose, that's a fight that's got to be stopped until you kind of clarify what's going on there. The cribriform plate's an extremely thin bone located at the base, but it does kind of communicate openly with the nasal pharynx. So clear fluid doesn't look like blood, doesn't look like mucus, doesn't look like anything else. Definitely have your doc take a look. I think if there's any questions, that's a fight that you probably have to postpone until you clarify it. The leak is an abnormal interruption between the normal defenses of the brain. Obviously, facial bone fractures, palpating around and looking to see. Nasal trauma, just the different forces involved, both frontal, direct frontal, lateral, all the hooks and all the rotations that you see here, and some combination of the above. And again, very delicate structures. A little bit about the different classes. This is probably more than we need to know, but class 1, frontal or frontal lateral from the front or side, the resultant damage to the septum. Class 2. Again, more side or lateral trauma, damage again to the septum or some of the cheekbone areas, and then high velocity, which would be rare to see in this, more car accidents than anything else. But fracture into the deeper bones. The ethmoid is around the sinus area beneath. Bridge collapse, abnormalities in the tip of the nose that didn't exist pre, are signs that there's been some more serious injury, and any kind of nasal bone disruptions. Anything affecting the eyes in terms of how they look or the space in between, more signs of serious trauma. Usually they're part of other things. And this is what they talk about. If there's serious injury to the nasal bones, you really have to think about the other structures, and that includes the neck. So obviously, your basic resuscitation and trauma, airway is always first, and then think about your spine. I mean, if they took that kind of damage up close in that area, did they sustain any damage to important structures here? Features of serious nasal trauma: epistaxis is just a nosebleed. We see those all the time, but profuse bleeds can be problematic. Deformities, both acute and deformities they come in with. Obstruction, checking for patency on both sides. The septal hematoma can be an issue here. Those do have to be evacuated, and we'll talk about that if you want to save cartilage. Diplopia is just double vision. Had a fighter who actually won a fight and later on admitted to double vision about midway through the fight in the 4th or 5th round. I don't know how he did it. He must have closed an eye or squinted or something, because it's extremely disruptive, to go from binocular vision and being able to see, one guy to all of a sudden having to fight two guys. This is a tough kid, though. He's a welter. And he finished the fight. He won the fight. And afterward, he says, Doc, about midway through, everything kind of doubled. And it was a serious sign. He didn't admit it, didn't talk to his corner about it. And then we went back through and sent him. He had a blowout fracture of his orbit. He had dropped one of his eye sockets had dropped just a millimeter or two. Did require facial plastic surgery to repair. He was out for 6 months or a year, if I remember that. And then this is just excess of tears before any damage to the medial canthus and the central areas of the eye socket that include the lacrimal ducts. Normally, your tears will drain through your nose if they're in excess, and that's why we blow our nose when we cry. But if that process becomes blocked, then you've got a fighter who's tearing up in a fight, one or both eyes, and you have to think about some sort of obstruction to the lacrimal ducts. It potentially could be, another surgical problem. And if it's interfering with the fight, certainly deserves consideration of stoppage. I mean, again, there's no absolutes. A lot of swelling about the eyes and nose, signs of more serious damage. We talked about the septal hematomas, the bulging, bluish, purplish masses extending from the mid-portion of the nose, oftentimes blocking the airways. Again, you may not be able to see everything, and not everybody carries a speculum, but just lean a fighter back or check for patency. You don't necessarily have to intervene urgently unless it is a significant septal hematoma, and we'll talk about drainage or aspiration in those cases. Don't forget about nasal airway and breathing. Don't forget about extraocular movements. The fellow that I mentioned with the orbital blowout fracture did manage to move his eyes. You'll see us do the H's and whatnot, and important on upward or lateral gaze. If one eye goes and the other eye doesn't, then you've either got entrapment or a nerve injury, and that's a fight that obviously needs to be stopped until you can address that. Open and close the mouth. The jaw should close just as normally, and it should be smooth. Checking the TMJs. Any disruption there implies some sort of disruption, be it fracture or dislocation, in either upper or lower jaw or in that TMJ. Documentation. This is the hardest thing to do on the small sheets that we get, but if there's something serious or whatnot, a small drawing or maybe something on the back to indicate what we're looking at or what we're seeing. Those sorts of things. Small fractures, nothing serious. These guys break their noses all the time. Probably nothing to get excited about. But skull injuries, facial fractures, the vision abnormalities we talked about, those require emergent, usually that night, referral for imaging. And usually all you need is a CAT scan with kind of fine cuts through the eye to see what, the midface to see what's happening here. But your ER docs can help you there, and knowing what the guy did and what he, what forces he was exposed to should change that CAT scan from just something simple looking at the brain to really a facial scan or something that's going to show the bones of the face as well. You may have to specify when he goes, though, that you're concerned about. Something's more delicate than is there blood in the brain, but is there disruption to the orbital walls? Emergent or first aid in that setting, you obviously clean the wounds, and anything that shouldn't be there comes out. Make sure your fighters are covered. Tetanus or antibiotics if you suspect any kind of spinal fluid leak or something that's concerned. Steri strips and monofilament to small stuff like that. Small fractures, small deformities, nothing much to do. These guys can have their noses fixed later on when they're done fighting, and they're ready to look pretty again. Those are some small nasal fractures can be done at Ringside. I tend to refer those on just so that we're not playing with people's faces on the side of the ring there. And we talked about the other possible injuries in this setting, everything from soft tissue to cartilage to hematomas and all those sorts of things. That's kind of repetitive. A little bit more on septal hematomas. The blood accumulates similar to the cauliflower ear underneath the cartilage in that septum, in that mid part of the nose. You can get either one-sided or dual obstruction there, and lean your fighters back, close a nose, ask them to breathe or exhale through it. Small ones can be aspirated, but then you may have to do this repeatedly. If the fighter forgets about it afterward, you should be seen more regularly afterward if he really wants to save and preserve his cartilage here. And then appropriate antibiotics if you're worried about more injury. Here's a good picture of a septal hematoma. So you're leaning the guy back and you're seeing these little bulging area here, maybe a smaller one here, but in this case you don't really need a speculum or any kind of fancy light if you're seeing that kind of bulge. You worry about the saddle deformity if you, very similar to what the ear can go through and end up in a cauliflower ear. If the blood sits and the cartilage is destroyed, then you're going to have a huge little defect or saddle on that nose bridge. A little bit more about spinal fluid leak, fairly rare. I don't know, has anybody ever had a leaky spinal fluid in fight? Just something to know about. I mean, trauma or other things. The difference between spinal fluid and regular stuff that comes out the nose is usually glucose. The spinal fluid glucose or sugar is pretty close to body sugar, and in a non-diabetic patient, it should be fairly correlating with what their plasma sugar is. There should be no sugar in any other fluid of the body that's not spinal fluid or blood or plasma. So that's an obvious one. You can get a small rim if you drop clear secretions on a white paper, and you get a small little whitish rim around it. That's a little suspicion that you've got more than just a mucus or other body fluid, that you've got some spinal fluid and things like that. Talking about testing and beyond, antibiotic leaks, those sorts of things. And obviously, if there's some kind of abnormal communication, then the risk of infection go up, including meningitis. A little bit about repair. That's probably more than we need to know here, but you can surgically repair these kind of leaks. Again, talking about low velocity trauma with just nasal injury versus high velocity trauma, and probably more MMA than boxing with the kicks. You got to worry about the neck and always kind of palpating back there. If you've got an unconscious fighter, obviously you're going to collar him until you can kind of re-evite later. NOE stands for the nasal orbit ethmoid kind of complex, and it's all the bones of that region and face. And you'll have some operative slides of kind of what happens here. How they present with the nose kind of deformed or whitened. Abnormalities of this canthus area is the inner rim of that eye, and again, the area where lacrimal ducts and tear ducts are kind of doing, and the nature of those injuries. A couple of photos of what we were talking about earlier with epiphora, where this delicate structure here in the inner portion of the eye is disrupted or blocked, and all of a sudden you've got a teary eye because of the lack of abnormal drainage in this region. CAT scans of disruptions in this area, multiple fractures in the nasal bone, and kind of how they appear on CT scan with disruption of the globes look different here. You've got an open eye, and you've got this eye here. Surgical repairs, that looks terrible. And then a small little plate, to kind of fix that up and fixate it. Other complications of these kind of trauma, bleeding. We've all seen the horrific bleeds that can happen in this setting. Our cut men are usually pretty good at managing this, but occasionally we're asked to be involved, and occasionally we're packing or doing things like that. Has anybody played with a rhino rocket or some of the? Yeah. Are you carrying them to fights or? No. Okay. Yeah. No. Okay. Just it seems like a nice little intervention if you've got a nice little bleed. But do you want to talk about a rhino rocket or how that thing works?
Yeah, I don't carry them to fights.
Yeah,
It's
but
the follow-up part of it.
Right.
So I just pack it or use put it underneath the frame.
Right.
To affect Kessel plexus. That also works too.
Okay. Yeah. Nice little tricks for the bad bleeds. Yeah. Generally the cut man will handle the small ones, but a little quick, on palpation for maxillofacial trauma. It's very similar to what we're supposed to be doing anyway. But starting at the orbital ridges, both upper and lower, checking for patency here in that upper jaw, putting your finger in, looking for disruptions along here, both cheeks, checking for that, nasal bone area. How does that feel? Is there crunching or crepitus underneath you? Is it symmetrical? Again, more checks of the upper jaw, lower jaw, and chin areas, just looking for any defects along there. More trauma. Remember, the eyes are also involved. Olfactory, nasal, smell, those sorts of things, and hearing loss or vertigo. These are all very important senses that are affected by the trauma that these guys are exposed to. And this looks terrible. Trauma workup. Don't be completely captivated by the bleeding or by the the grossness of a cut. Just remember there you have to do a complete evaluation of the fighter too, and starting with brain function and breathing, things like that. A little bit on the orbital fractures we talked about, and I had a direct experience with this one. This is a baseball. It could just easily be a boxing glove. And the transmission of forces, because of that nice soft socket with the bone above and below, the forces are directly transmitted to all the walls here. And these are, again, very delicate, very thin walls. So the right punch into this area can certainly cause either a bottom or a floor fracture. You can go upward or posteriorly and cause damage in these areas. A little bit more about anatomy of this area. Every color is a different bone. So looking at the eye socket, you can tell just how many, bones are involved in this region, and each one requires, its own sort of repair. Other signs of orbital fracture, obviously the black eyes, any kind of sensory deficits, this paresthesia or just complete numbness underneath the eyes, that branch of the fifth nerve or facial nerve is also affected by this. We talked about diplopia, the double vision, and sometimes it's only on extreme views, so that H becomes important when you're waving the finger and asking the fighter, not only looking at his eyes, but did he experience double vision, or is his vision affected? There's a nice picture of this upward gaze defect here, and then double vision, and then the actual drop of the eye where one eyeball is pushed back a little bit, this enophthalmos. Clinical radiographic presentations, there's a couple nice pictures of fracture and how we pick this up, both the obvious bruising or ecchymosis around the conge or the orbits here. Crepitation is just that feeling you get of almost air directly underneath. If anybody's ever popped those little packing or those little plastic bubbles you get from FedEx or UPS, it's a very similar sensation to that, except the bubbles are a lot smaller. The palpebral fissures, basically your folds and your eye folds, if one looks different than the other. Pupils, we all learn, are carrying the lights for a reason, and this, although a rare injury, may give you a hint as to something more serious going on, the double vision and the disruptions in the orbits. Treatment, small defects, nothing to worry about here, but obviously any sort of serious symptoms like we talked about, you've got to extend on. Here's a nice example of upward gaze abnormality. So this fighter's been asked to look upward and to the left, and one eye's obviously doing this, and the other eye just isn't capable of it. And here's the CAT scan explanation as to why. He's got, on the CAT scan, the patient's lying away from you with his nose up in the air. So this is right side, this is left side. Right side is fine because all the structures here look normal. Left side, you can see these disruptions. You can see a small hematoma in the sinuses, and this nice wall is also disrupted. This is after repair. This is during the repair itself, and now the eyes are moving again. So nice job there. And that's all I got.